Nick Majerison here. Welcome along to Top Med Talk. This is part 2 in the Frailty Assessment Why and How talk that we were putting out yesterday as well. This is a fascinating talk, I think, really, really interesting. It's on the subject of frailty, assessed both as a diagnosis and a reality of often elderly people who suffer from it. And we're halfway through the conversation at the moment. Find out where the previous part is on our website, topmedtalk.com. If you go there, you'll be able to find the previous podcast. And also, you'll be able to find all about the ASA, which is where we are at the moment in San Francisco. And we're very excited to be here. It's going really well. You're going to be hearing some stuff from here on the podcast feed soon. But you may already be treating yourself to some of the live broadcasts that we do on the Top Med Talk website. topmedtalk.com. Go on there. You'll find out how we live stream the event. Also, if you want to get involved in the questioning side of things, yeah, that's right. You know how listeners are suggesting questions if you've been listening in. How are they doing that? I tell you, go to slido.com. Once you're on slido.com, fill out the following it'll ask you for an event code. Here's the event code. Hashtag TMTASA18. That's hashtag TMTASA18. Put that into the event code thing. It'll bring you to a page that then gives you the chance to ask questions and to vote up questions that you think are particularly good that are already on the screen. If you do that, you can become a bigger part of the conference, of course, the ASA, without even having to be there. Slido.com. And don't forget, of course, topmedtalk.com to actually listen to the conference. Got more to tell you about that in a bit. Before that, though, let's have a listen to part 2 of this excellent talk from Dr. Bobbie Jean Sweitzer, and it's Frailty Assessment, Why and How.
Top Med Talk.
So most older individuals particularly, and actually even, other patients, younger patients, are more willing to undergo treatments if they think that there is going to be more benefit than harm. Not surprising, right? But I think one of the things we often fail to talk to patients about too is how long it will take them to get back to their normal. And so, if you're 20 or 30 years old and it's going to take you even a year or 2 years to get back to normal, you usually sort of look at those odds and you say, it's a long time. I'm going to give up a lot of my, current sort of life and whatever. But I probably have 40 more years to live, so I'll pay that price or I'll spend that time doing that. But if you're 75 or 80 or 85, and it's going to take you a year or two to get back to even where you are now, you start to say, I don't know that I have that much time left, that I want to give up that much time. So generally, if there's a low intensity of treatment, whether that low intensity is cost, time, pain, suffering, but the payoff is returning to your same level of health before you were ill, or a better level of health, then most patients are willing to undergo that. And even when there's a high burden to pay, if it's returning to the current level of health, patients are willing to undergo that treatment. But as soon as it starts to factor in, particularly for elderly individuals, that they are going to have some functional impairment, they will never drive again, they may never live independently again, or it's going to be a significant amount of time, or they're going to spend a lot of time in pain or suffering or having to undergo physical therapy rather than being able to go to their granddaughter's birthday party, you can see the willingness to undergo treatment rapidly starts to fall off. So I think these are the kinds of conversations we need to start to incorporate and be skilled at having with patients. And increasingly, as there's concerns about anesthesia effects and the effects of anesthesia on patients, this is right in our backyard. So even if you have no interest in sort of, the long term or the morbidity or being part of this whole team of pre-operative preparation of patients, you're going to have more and more patients asking you questions like, am I going to be back to, my baseline? Am I going to be able to, play bridge or do whatever, they want to do? Am I still going to be able to do the New York Times crossword puzzle? And so that gets into also being sure that your patient is capable of having those conversations. So I think it's really important that we, become educated and know about health literacy. And this doesn't just apply to frail patients; it actually applies to a lot of patients because different, cultural or educational backgrounds, language burdens will have patients who may be literate, meaning they can read and understand the spoken word, not be health literate and not really be able to either understand the meanings of certain medical terms we use or just be able to process the meaning of things like, disability or complications. But let's get a little back on track with a couple more things showing that why frailty is so important, I think, to add to our assessments. And this was a study done out of Hopkins by one of the early surgeons who adopted this idea of assessing patients for frailty. And they looked at ASA physical status scoring again. And you can see when they added frailty to the ASA physical status scoring, or they add to the RCRI, which is used as a predictor for cardiac complications. Adding frailty significantly improved the ability to predict outcomes. And they looked at both mortality and morbidity, and frailty helped with both of those. We talked a bit about cognitive decline. Frailty can also predict patients who are at risk for delirium. The strongest predictor of patients who are going to get post-op delirium are those who have cognitive decline already or have suffered already an episode of delirium or cognitive decline. But simply being frail and still being cognitively intact significantly predicts those patients who will be at risk. Again, I think gets to the heart of what we do. We've been challenged that we have risk assessed patients cardiac-wise. We do risk assess them based on their blood pressure, their diabetes. But the primary focus of anesthesia, which is the brain, we haven't been doing a very good job of either risk assessing patients or understanding how to predict who's going to be at risk. We don't understand a lot about which drugs, what effects at different anesthesia techniques have, or how to even have conversations with patients now that this is much more out there in the lay literature of concerns about the effects of anesthesia on long-term functional and cognitive abilities. This was a study looking at mortality with cognitive impairment. It was 29% mortality 1 year after a hip fracture in those patients who did have cognitive impairment. Again, pre-op activities of daily living predicted post-op delirium at a 12-fold rate. Pre-op impairment increases functional decline up to 2 years post-operatively, both physical as well as mental functional decline. Cognitively impaired patients are twice as likely to be discharged to extended care facilities after surgery. And even mild cognitive impairment can increase your risk, and it's often not apparent. It's kind of the same thing. The older person who just doesn't quite seem as sharp, it's almost like we just take that for granted, or we don't even spend enough time talking to that person to be able to tease out, or we haven't known them long term. Even their primary care doctors don't know them long term enough to have seen that gradual decline that they've had. And 50% of patients with dementia currently are undiagnosed. Simply asking people about falls. It's interesting that it's asking a fall history and obtaining a history of a patient having fallen 4 times in the last 6 months is 100% predictive that patient is going to have a significant post-operative complication. There's very few things that we can do, very few risk assessments that have 100% predictive value, much less a simple question like, have you fallen and how many times have you fallen in the last 6 months? And it's just again, I think we don't even ask that question frequently. And if somebody does report it, we often just think that, they're tripped or they need a cane, or it's just, we don't take it seriously. But it is a very robust predictor, and across fairly different studies and different types of procedures. The American College of Surgeons and the American Geriatric Society got together and published a guideline a couple of years ago. I was dismayed that the American Society of Anesthesiologists was not part of that. I don't know why that was, whether we weren't asked or we declined to participate. But they came out with a 2-part recommendation. The one part is a preoperative evaluation piece. The second one is a inter-op and post-op piece. I put both the references up there. But they essentially said that all patients 65 and older should be screened for frailty. So that's what we've adopted at Northwestern. We started out with a pilot study with a few surgeons who were interested. And we reached out to, especially some of the higher risk thoracic, GI, those kinds of procedures. And now we have essentially either rolled it out or in the process of rolling it out to all patients, with the exception of cataract surgery patients. The screening for our healthy, non-frail patients takes less than 5 minutes. There was another study showing that they could do it in less than 2 minutes. This is what our screening tool looks like. I know it looks a little bit busy. This is the paper screen we have. We actually now do it in our Epic, but it was a lot harder to sort of project that. And I just wanted to focus on the purple left-hand column to show that these are the 5 categories of assessments. We took this from mainly from the McCary article that I showed you earlier, Marty McCary's work from Hopkins, because that was a study. It showed results. It was a randomized controlled trial. He had gathered that assessment from a geriatric, more lengthy assessment that had been validated, and it spoke to the surgeons because it was in their literature. So he wanted something that resonated with the surgeons. So it looks at it's called shrinkage, which is weight loss. Then weakness, which is measured by grip. We bought them on Amazon. I think they cost like $25. The first one we bought was kind of cheap and it broke, and then the second one we bought, I think it cost a little bit more money, and it's lasted us the whole time. So if you want to send me, I think my last slide has my email on it. I can send you pictures or a name of the ones we bought. They're really easy to use. Our medical assistants do this, and then they score it, and then it's available to the provider who sees the patient, and it's available to the surgeon. The third category is exhaustion. So you ask the patient how they feel about if they feel tired when they're doing activities. And then it's physical activity is the fourth one, which is a little bit different because you ask them about specific activities, mainly those of activities of daily living. Do you bathe yourself? Do you dress yourself? Can you get in and out of a chair? Do you make your own meals? And then the fifth one is an objective evaluation, which is walking. So we marked off an area in our clinic, a distance of 15 feet, and we got some little timers. Some people use their stopwatch on their phones, and we just have the patient walk along that distance, and we time them. And then the right-hand side, the far right-hand side, shows you the categories of normal or abnormal. So it's really very simple to use. It's very 2 of them are objective, 3 of them are subjective, but then you get scoring that's based on a numerical value. And then we do a mini-COG. Some people do mental status exams. That takes a little bit longer. The mini-COG is very quick. It usually takes a minute or less. And this is what you do. It's a measure of recall and drawing a clock face and seeing if the patient can draw that accurately and remember 3 words. Another test that some people use is the time to get up and go test. So you have a patient sitting in a chair, and then you have them rise from the chair and walk a certain distance, and you measure that time, and you can just Google. There's charts that show you what's considered normal or abnormal. You can also evaluate just activities of daily living, as I showed you that previous slide. I think that if you're going to do anything, asking patients about activities of daily living is probably one of the more robust things. Asking about falls, and then if you are going to enact measures, you can either refer them to a geriatrician, you can involve palliative care, you can alert the surgeons, or you can do certain things like prehabilitation. And we're in the process right now of kind of deciding how we're going to take this to the next step. We've so far just primarily been screening patients, but I'm going to talk a little bit later here about why even screening individuals has been shown to be beneficial. And I've piloted with a couple of surgeons about our thoracic surgeons. We've done some prehabilitation on some of those patients and showed some good results. If you want to, again, talk with patients about these risks, I would urge you to consider utilizing patient decision support tools. I don't know how many people are aware that the American Society of Anesthesiologists has some patient decision support tools. Is anybody? Yeah, they do. If you just go to the asahq.org, and I think you put in patient decision support tools or decision support tools, you will find there's, I think, one for pregnant patients. There's one I'm going to show you on regional anesthesia. If you just Google, not the ASA, but just Google in general, you'll find other decision support tools, some from Australia, some from the UK, that I have borrowed for various reasons. But these can be utilized to help patients, any patient, but particularly those that you suspect may be challenged in being able to make decisions and weigh a lot of complex information, particularly when it comes to risk. And what is, required of the patient and what is likely to be the results. So this is an example of the ASA decision support tool on regional anesthesia. You can download it, you can print it out, or you can use it online. And it has been shown that by using something like this, patients are much more likely to want to ask about regional anesthesia or to be willing to accept regional anesthesia and to be better informed. There's even some information in the literature to suggest that patients who have used decision support tools are less likely to sue their doctors. They're more satisfied with their care, they feel better informed, and they may have overall lower complication rates because they perhaps are making different decisions, or they also understand what is sort of, required from them. So I really encourage you to utilize these kinds of tools if you decide you are going to engage in this frailty screening, and it may even help you talk to your surgeons. This is a guideline that just came out from the Society of Perioperative Anesthesia Assessment and Quality Improvement. How many people know about SPACI? SPACI is a multidisciplinary organization started by some anesthesiologists, but there's a lot of internists, administrators, nurses, and they just came out with a guideline that's published in the Journal of Clinical Anesthesia on frailty screening and best practices. And there's both anesthesiologists and internists on this guideline, but I think it's very complementary to that American College of Surgeons, American Geriatric Society guideline that I showed you earlier. I think if you look at those three documents, the two from that earlier double group and this one, it can give you a lot of great information to start with if you want to do frailty evaluation screening. But this is what I mentioned earlier about, even if you don't do anything about the patients that you screen as frail. So our patients are labeled using our tool as frail, pre-frail, or non-frail based on the numerical value. And this study that was published in JAMA Surgery showed that just simply doing something similar and screening patients for frailty using a standardized tool and labeling them significantly impacted mortality, which is pretty amazing. They didn't have any formal process to deal with the frailty. They just informed the surgeons. But what they found out was there tended to be more palliative care and geriatric consultations generated by the surgeon if they were informed their patient was frail. There were more palliative care and consultation services by the anesthesiologist if the patient was labeled as frail. There was less use of things like benzodiazepines and some other medications that we know may be problematic for patients when patients were labeled as frail as not frail. The nurses on the floor were more likely to band patients as fall risks. They lowered their risk of falls in patients, just again by highlighting and labeling that this was a risk for patients. And it was kind of amazing that they actually, showed a difference in mortality without any formal intervention. It was just a screen. So you can imagine that now if we do intervene on these patients and do have a formal way of even, making sure they get their glasses, making sure they get their hearing aids, making sure they get canes, making sure that, somebody talks to them about when they go home, they shouldn't have throw rugs on the, many patients don't realize when they go home, they're not going to be able to get up to their second or third floor apartments because the surgeons aren't going to tell them that, right? And they don't go back to their primary care doctors typically. They just get scheduled for surgery and they're on the schedule and it's, business as usual. So that just shows that, yes, improved survival, short-term as well as long-term survival, just simply screening and labeling patients as frail. So I think it takes a village, and I mentioned, at the very beginning of this, how I think we need to partner and with all the people that need to take care of patients. I think that, if you're lucky enough to be in an institution where you have geriatricians and palliative care physicians, they are invaluable in helping you talk to patients, and make sure you understand the patient's perspective and priorities of what they want their life to look like on post-op day 1, post-op day 30, and if they're lucky enough, post-op day 365. Thank you.
Don't forget, of course, you can meet the Top Med Talk team very easily. Just pop along to one of the conferences that we're at, pop over to the table and say, hello, I like listening to your podcast. We've had some people do that. It's very pleasing every time it happens. It's even weirder when they go, oh, I recognise your voice. I listen to your voice as I drive into work. Anyway, listen, it's a lot of fun to meet people who listen to the podcast, and more people are making the point of becoming regular listeners to Top Med Talk. So if you're one of them and you want to get even more involved in the world's favourite medical podcast, here's how you do it. First of all, you can have a look on Slido, where you can submit questions to the ASA in the various different events that we attend. Slido.com, the password or the event code that you need is hashtag TMTASA18. Once you put that into the box that pops up when you are on the Slido.com website, you'll then able to go through to the main page where you can submit your questions and vote up questions that you think are particularly good that other people have suggested. Also, don't forget our website, topmedtalk.com. There you can listen to the conference as it goes out live. Now, a lot of those talks then get later turned into podcasts, like today's podcast, which was originally streamed live from the website. However, we can't guarantee that all of them get turned into a podcast. It varies. There's sometimes, reasons why we can't turn them into a podcast or whatever. So the best way of hearing all of the content is to listen to it live online at the time, and then, of course, to subscribe to the podcast and get the filleted highlights as time goes by. Oh, and finally, it's worth mentioning, Top Med Talk is, of course, the broadcast arm of EBPOM, Evidence-Based Perioperative Medicine. And if you go to the ebpom.org website /meetings, so that's ebpom.org/meetings, what you'll do is you'll find a whole area where you can look at some of the forthcoming conferences that we're going to be in attendance at, and you can make your plans to join us in the flesh. ebpom.org/meetings.